Thanks again for joining us today for this webinar on the theme of creating sustainable solutions to address nicotine dependence in the behavioral health setting. My name is Jim Pavlik, and I'm the Program and Policy Analyst at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus. In my capacity here at BHWP, most of my work is in assisting organizations to adapt their workflows for a variety of clinic quality improvement initiatives, mostly focusing on chronic disease prevention and control, with a particular emphasis in tobacco cessation interventions. Today's learning objectives are simple, to highlight several actions that you can take to move your organization in the direction of providing a comprehensive suite of effective, efficient tobacco cessation interventions, ideally with the resources you currently have. And to do that, I will have to define what we mean by low burden. I will have to list and describe those actions, and I'll provide some resources to guide you as you adapt the best practices defined here to meet the specific needs of your organization and the populations that you serve. Before getting too far along, I want to address the term sustainable. Typically in a presentation like this, we would talk about scalability and sustainability. One point I'd like to make is that as a general rule, all scalable initiatives are also sustainable, but not necessarily the other way around. So of the two, being sustainable is the more important. And I'm essentially using the terms low burden and sustainable as synonyms. The former emphasizes the impact on your staff today, and the latter emphasizes the feasibility of maintaining these improvements over longer time horizons. In my experience, changes perceived as low burden today are much more likely to become sustainable over the long haul. So by low burden, we mean primarily two things, one economic and one psychological. One, the benefits delivered are worth the cost incurred to deliver them. And two, those benefits are understood and appreciated by those who perform those services. On number one, in a narrow sense, we could be talking about ROI, or return on investment. If we determine that the project costs $100 per customer, but saves the organization $200 per consumer, we'd say that the project is worth doing. But we may consider it worth doing even if the ROI were narrower, provided that the project serves some other purpose important to the organization, like fulfilling our mission to care for our community, for example. On number two, we're primarily talking about the culture of the organization itself. Many tasks have been forced on employees over the last 20 years or so, and caregivers spend anywhere between 40 and 70% of their entire day doing administrative work instead of providing care. No action, program, or suite of services can be considered sustainable if the staff are actively pushing back against the execution of that program. Which is all to say that we define low burden initiatives as those that satisfy at least the first criteria and which are housed within a robust policy regime that aids in the satisfaction of the second. To satisfy criteria one of sustainability, an intervention must work. It must convey some benefit to the staff directly, but more importantly in this realm, to the consumer. A tobacco cessation intervention must successfully get people to quit tobacco. So which interventions work? To know that, we have to understand some things about quit attempts in general and where we can impact them. So I want to share some back of the envelope calculations, but first I want to say what I mean by that. The numbers that will appear on this slide are approximations. They take a lot of things for granted and they have not been vetted by an epidemiologist. To emphasize the lack of precision here, I've done a lot of rounding down to show more conservative figures. I also chose the lower and upper ends of certain estimate ranges selectively to favor conservatism. This is because my goal here is not to exaggerate what is possible, but I'm also not doing this to offer actual projections that might be truly achievable. I'm doing this merely as an exercise to build intuition around the scale of our potential impact and for whom our efforts will be most impactful. We begin with about 500,000 adult smokers in Oregon, about 75% of which report today that they would like to quit within the next year. Now, these figures are for adults only, so it's worth mentioning that most individuals younger than 18, when they're asked if they imagine themselves as a smoker at 30, say no, they don't. In fact, by the time tobacco-using teenagers reach the age of 18, about 50% of them have reported having tried to quit and failed. But going back to our adults, when we asked them if they went one day in the past 12 months without smoking with the intention of becoming abstinent, only about 65% report that they did. The group represented by the gap between those who want to quit and those who actually try each year, I will refer to as Group A. A group of about 50,000 folks with a 0% abstinence rate at the end of 1 year because they didn't even try. A group that if we could have reached out to them all and persuaded them to use counseling and medication could have resulted in about 12,500 additional quits. I want to take a pause for a moment after these two statistics. Many presentations begin with an argument, an appeal to why are we talking about this? Why does it matter? I didn't start with one because you all registered for this webinar, so I assume everyone is on board with the general idea that helping our consumers to quit is a good one. Nevertheless, there are some common misperceptions that I feel compelled to address at this moment because this is where they become relevant. Because I'm tossing around numbers like how many people want to quit and what are their success rates if they try. It's worth figuring out if the behavioral health population may be significantly different than the general population reflected in these three bullets. One of the major misconceptions is that individuals with behavioral health conditions smoke at higher rates out of a greater need. This greater need then leads to a lower desire to quit, and the lower desire to quit impacts success rates negatively, resulting in higher prevalence rates. And we do know that the behavioral health population does have a higher prevalence rate, about 2 to 3 times higher than the general population. So this pathway seems plausible. So it's worth stepping back to consider, do individuals in the population, the behavioral health population, want to quit at lower rates than the general population? And what impact do their conditions have on their ability to quit? It is indeed the case that the individuals in the behavioral health population share certain inputs and outcomes, and among them are poverty as children and lower educational attainment as adults. These factors combine to create lower incomes, higher chronic stress, more involvement with the criminal justice system, and a host of others. But it is also the case that the tobacco industry is aware of these associations and have deliberately marketed their products to these groups, thus driving up prevalence rates beyond any hypothesized natural rate that may occur in such populations. It is also the case that tobacco use causes, contributes to, and aggravates various conditions. It primes the brain for future addictions. It can increase pain sensitivity and increase the power of certain opioid effects. It can dampen the power of various therapeutic drugs, including certain painkillers like acetaminophen. And in addition to the causal and associational links between smoking and behavioral health, co-treatment of nicotine and other substances can positively affect the chances of remaining abstinent from both. While individuals with a behavioral health condition only make up about 25% of the total population at any given time, they account for about 34% of all cigarettes sold, which is to say that not only is the prevalence rate in this population higher than the general population, they also smoke more. This means more instances of chronic disease, more money being spent on this habit, more time out of their day taken up by cigarettes or smoking. In short, while the prevalence rate is higher, the need and desire to quit are also higher. So to correct our misconception, what we actually see is that those suffering from a mental health or substance abuse issue are more likely to lack access to therapeutic services and thus rely on smoking as self-medication or a coping strategy, which drives up use. This vulnerability attracts the interest of the tobacco industry, which increases its outreach to this population, which further drives up use, both of the numbers that use and the amount that each uses. This increases the financial and physical toll of tobacco, which increases the desire to quit, but it also increases dependency, thus making it more difficult to quit without access to resources, which, as we've already pointed out, they likely don't have access to. And this is how we get to higher prevalence rates. In short, when we talk to individuals in this population about their desire to quit and their willingness to do so, we see that the higher prevalence isn't about the desire or willingness, but rather the support they're offered and, as we'll see later, whether the manner in which that support is offered empowers them or not. One final note. Several years ago, BHWP had the opportunity to collect a convenient sample of over 600 individuals in substance abuse treatment facilities across Florida. We asked those individuals whether they were current tobacco users, whether they were ex or non-users, and if they were current users, whether they wanted to quit in the next year or never. And here are the results that we found. About 31% of folks were ex or non-smokers. Of the smokers, 63.4% of them said they wanted to quit within the next year. Not quite as high as the national figure, but all things considered, pretty close, and definitely much higher than most clinical directors or senior leadership had expected. Now to return to our previous point. One area where we can make an impact is trying to reach this missing 10%, this group A, the group of about 12,500 potential new quits if we could have reached the audience of 50,000. But let's put a pin in them and look at the 325,000 people who do make an attempt. What happens to them? Of those, most of the quit attempts will be made without any help at all. We used to say 95% of quit attempts were made with no help at all, but with the rising popularity of quit lines, the known safety and relative affordability of NRT, and growing internet connectivity, more and more people are availing themselves of some assistance. Here I'm using the figure of about 60% for unaided quits. It's a more conservative figure than 95. These numbers vary widely across states, and I don't actually have Oregon's figures. Only about 7% of them will be successful. So this leads us to group B, a group of about, conservatively, 195,000 Oregonians each year, and of that group, about 13,650 will successfully quit on their own. If we could have persuaded all of them to use counseling and pharmacotherapy, there would be an additional 35,000 successful quits in this group each year. So here we can see all of the various quit rates, successes by method of quit. You'll see that I use 7% to illustrate the unaided quit attempt, and I use 25% as the number of choice for medication plus counseling. I did this to create the most conservative estimates of our back-of-the-envelope best-case scenario. And this leads to Group C. Group C is the collection of individuals who will seek out an evidence-based best practice, but without the right supports will demonstrate successes at the lower end of every range. That is, someone may seek out NRT and counseling, but if they also sought our support, adding our guidance to their toolbox, instead of the 25% chance I gave them here, they may have closer to 30. The bottom line is that the evidence base suggests that the best thing a tobacco user can do is get access to tobacco cessation counseling and combination nicotine replacement therapy or varenicline. All of our concrete actions defined today are designed to impact groups A, B, and C individuals. So what are we going to do? We're going to use the 5 A's to implement and deliver the tobacco cessation recommendations of the United States Preventative Services Task Force. If that name sounds familiar, it may be because anything with a grade of A or B from the USPSTF must be a reimbursable service for the insurance policy to be considered compliant to the Affordable Care Act's Essential Health Benefits section. And those services are specifically telephonic counseling, group support, individual counseling, peer support, and medication-assisted treatment. Some of you are probably familiar with the 5 A's already. And some of you may have opted for the shorter 2 A's and an R. In either case, you're probably nervous that we're about to start a 5 A's training, and we aren't. Many more of you will be even more familiar with SBIRT, or Screening, Brief Intervention, and Referral to Treatment. Because SBIRT seems to map most directly onto the 2 A's and an R, I would like to draw out the difference between the two. In short, the brief intervention component of SBIRT is more complex than the advised component of the 2 A's and an R. We will discuss referrals in a bit more depth later, but suffice to say that to make a good, effective recommendation that a person will consider following through, you have to do a bit of the assess and assist pieces. And whenever you make a referral for an individual with whom you will maintain an ongoing relationship, you should be aiming to close the loop a bit to make sure the consumer accesses those referrals and to gauge their progress. For example, if nicotine dependence treatment is added to a treatment plan to enhance recovery from alcohol, then the case manager responsible for checking in on the alcohol-related services should also be following up on the client's engagement and progress in the psychoeducational or support group the patient was referred to for nicotine. And we will recommend supporting these two things with a robust, carefully designed policy that begins with an analysis of the workflow. So now that I'm clearly about to begin our second section on planning, you should be wondering if I'll ever get to the part where we're doing something. And I will, I promise. It's worth pointing out at this time that planning well, while itself not an activity that generates revenue, reduces expenditures, or improves consumer health outcomes, is nevertheless absolutely critical. If you remember when I said earlier that in order to satisfy the most fundamental property of sustainability, an intervention must work, well, in study after study, one of the critical factors into determining whether a workflow adjustment or a new organizational policy succeeds or fails is the time spent in planning and the effort given to creating an honest quality course of action. And crucial to the planning process itself is accountability. Who is responsible for doing what? In the realm of tobacco cessation services, supports, and policy, a crucial figure that dominates all the others and the formation of which predates all other steps is the Wellness Committee. If the Wellness Committee's only function is to analyze and rework your tobacco workflow, then you can feel free to call it a tobacco committee or something similar. We advise against creating a committee with such a narrow portfolio for a variety of reasons. But the two most important are that a committee with a narrow portfolio may quickly run out of steam while your new policy is in the doing phase. But more importantly, tobacco use impacts nearly every aspect of our consumers' lives. It causes and aggravates the mental health conditions they're seeking care for. It causes and aggravates the development and progress of chronic diseases, which diminish their ability to find work, maintain housing, etc. And those things, in turn, can exacerbate chronic mental health conditions like major depression. It strains them financially and on and on. A wellness committee serves as a central point of contact for the creation and dissemination of the new policy changes. It is the wellness committee which will serve as the main point of creativity, taking the best practices mentioned in this webinar and elsewhere and modifying them to fit the needs of your consumer population and your staff's willingness and capacity. For more on the wellness committee, like who should be on it, be sure to download for free our tobacco-free policy toolkit, which is filled with a variety of tools and worksheets to help guide your work in this area. Unfortunately, there is a gap between no burden and low burden, and this gap is important. So one way to get more things into a workflow is to first analyze your current workflow and get rid of all the stupid stuff. In an effort to reduce unintended burdens for clinicians, leaders at a health system in Hawaii asked all employees to look at their daily documentation experience and report anything in the EHR that they thought was poorly designed, unnecessary, or just plain stupid. Basically, this health system allotted a certain amount of time for anyone to report anything, and they did that. So critically, some of these things were really just poorly designed, and they were able to fix them. Some of these things were unnecessary, and they were eliminated. Some of these things seemed unnecessary, so the team in charge was able to explain why those steps were necessary they were able to explain why those steps were necessary to complete and why that information was necessary to collect. And some things were holdovers from previous eras, previous initiatives, actions that were necessary and smart once, but not any longer. In all, this system estimated they were able to eradicate thousands of hours of wasted time. Now, this example here is from a hospital system with complicated and nuanced EHRs. But when I, Jim Pavlik, worked in community behavioral health, there were some small redundancies that I noticed that could have been eliminated. A rough estimate in that regard indicates I was duplicating information, costing me roughly 3 minutes per note. I had around 6 clients each day, and I worked 5 days a week, 200 days per year. That's 60 hours wasted each year just for me. Multiply that by the hundreds of employees in my organization, many of which had more complicated notes than I did, and you can see the potential for real savings. More important to me than the savings is the message you're sending to the staff. You're saying your time is valuable. We know, we understand, and appreciate that. Let's put your time where it matters most to you, with your clients. Preceding systems changes with this elimination of stupid stuff can also imply something about the new things you add. It says, these things matter. We're the kind of people who value your time, so we wouldn't add anything that dilutes your ability to care. Eliminating stupid stuff is not a requirement. Only you can know if your current systems have started to suffer from service or administrative creep. But before you embark on major alterations of your workflow, you do need to know what you're currently doing so that you can find opportunities to enhance those processes with tobacco-related additions. If you are thinking of adding services, then try to identify the processes that you already have in place for patients that require complex management, say, for example, chronic diseases. And if you have them, other protocols for use with dealing with comorbid positions. Think of it this way. Nicotine dependence is a dependence. Dependence in general is a chronic recurring condition. Tobacco use is a health behavior leading to known health outcomes. Tobacco use leads to the development of known physical conditions, most of which are also chronic conditions like various cancers, heart disease, COPD, and diabetes. Tobacco use, like many chronic conditions, is treated with FDA-approved medicines. Tobacco use, like many substance abuse-related conditions, have established best practices given an A or B grade from the US PSTF. Tobacco use can be treated with counseling. So in those scenarios, try to figure out basic things like who does patient intake? How are patients sorted or triaged? Where do they go next? And then add tobacco services accordingly. A common workflow, for example, may be one, an intake process where basic information is collected, including the patient's current drug regimen, their brief medical history, and current complaint. Some common screening questions may be included at this point as well. Two, then the person will be sent to someone qualified to assess whether the complaint is a certain specific issue and then also how severe it is. Then the person will be sent to someone qualified to reduce the severity of that complaint with an aim of moving the consumer to the least restrictive environment. This may be a prescriber who can start a new prescription or just alter current ones. Then the person visits an assigned case manager who will connect the client to other services, including potentially a therapist, an in-home case aide, relevant therapeutic or educational group support. The case manager may also at that point refer the client to resources outside the organization, and then ultimately to billing and discharge. Now that may or may not look like a common consumer route to you. The point is not that we all should adopt a model workflow that would work anywhere, or even that all consumers within your organization would follow the same route. They almost certainly won't. The point is to refer back to those evidence-based tobacco interventions and make sure that all the people who see the patient are trained to provide the service that most corresponds with the service they are already providing the client. For example, an intake person asking for current drug use and recent medical history can also screen for tobacco use. A person who can perform a PHQ-9 can also do the two-question heaviness of smoking index to determine nicotine dependency levels. A certified addictions counselor that the patient is assigned to work with for the opioid recovery can also provide counseling on nicotine dependence recovery. A psychiatrist or psych nurse with prescribing authority who is familiar with the patient's current regimen is the ideal person to recommend, explain, and monitor NRT use. The complicated workflow on this slide does not seem to convey low burden. I admit that. But there are three things I want to point out. If you were to map out any of your chronic disease consumers' workflows, it could look a lot like this. The second thing I want to point out is the distribution of the work. Although tobacco cessation itself can require a lot of intense service or time with the consumer, it all doesn't fall on one person, and so is experienced as a low-burden task for many rather than a high-burden task for one. And finally, the third thing. I want to point out that not everyone gets every service. While the intensity does go up for each remaining consumer, we can direct clients out of this workflow as they reach their appropriate level of intensity. The slide here is one way to conceptualize this. I'll introduce another one in the next section. As I already mentioned, this isn't a 5A's training, but I do want to return to this concept as it is the critical way to tailor our services in such a way as to ensure that everyone gets as much support as they need and that no one gets too much. That is, I want the 5A's adopted to ensure healthcare equity, not healthcare equality. One way to make sure that an intervention is sustainable is to make sure that it works. So we want to provide the maximum support required to, one, motivate a quit attempt, and two, maintain that quit attempt. The second thing we want to do is not provide any more care than is necessary. Additional time spent with a patient that doesn't need it, additional pharmacotherapy provided to a consumer that doesn't need it. These are both resources that once spent can't be spent on another consumer who does. Also, ramping up intensity on a client that doesn't require it may actually create resistance in the consumer that was initially willing to accept assistance from us. So ask is our screener. Simply put, we want to know if the person is a tobacco user. If not, they might not need any additional tobacco-related services. And this could represent anywhere between 20 and 55% of your entire consumer base who wouldn't need to go any further. However, we do want to screen each of them every time they come in. While this is true for everyone, it's especially true for young people below 18 and for anyone newly exposed to high levels of smokers, like those recently assigned to residential treatment, jail, or prison. And I'll add that highly agitated or unconscious individuals don't have to be screened immediately. I'm often asked, after I say what I just said, if every patient at every visit is realistic when consumers are coming in maybe multiple times per week. And I have two answers to that. The first is probably. It literally only takes a second to ask and record an answer. And the second response I have is, I don't really know. Only you know if your workflow and staff have the capacity to do that. If you elect to not do it, every patient or every consumer at every visit, I would set some parameter to measure against. Once every 12 or 24 months are two common standardized measures. I'd prefer more frequently since both can change their minds overnight. Moreover, it's not just about obtaining a smoking status. Ideally, you'd want to make sure you catch anybody who suddenly changes the levels they smoke. Changing levels can be an early warning sign of an acute onset for several conditions of concern, including major depression and suicidality. It can also be indicative of major life changes like loss of food stamps or other nutritional support or loss of sleep. And lastly, we should always keep in mind that as a person's consumption of smoke changes, the potency of their other medications may be changing as well. That is, as smoke consumption goes down, other medications become stronger. So frequent check-ins to check for tobacco use levels has a solid grounding in the provision of medication-related services. Next, we want to advise all tobacco-using clients that quitting tobacco use is the best thing they can do for their health. This message should be delivered in a non-judgmental way and also connected to something that makes the advice immediately relevant to the client, like tobacco use's connection to the actual reason they're in your office, for example. From a workflow efficiency standpoint, you will have to make the calculation of how far up that advice comes. The higher up the advice comes from, the more expensive each minute becomes. On the other hand, from an effectiveness and efficiency standpoint, an intake staffer advising someone to quit doesn't really impact their cessation rates. However, when that advice comes from a physician, it more than doubles the chances of abstinence after 5 months. In the next stage, we want to assess the client on two fronts. First, we want to assess the client's willingness to talk with us. If they are pre-contemplative about their nicotine use, that is, if they're among the set of individuals who have no intention of quitting ever, then we don't really want to force any further engagement. And this could be anywhere between 20 and 25% of all current tobacco users in your system. For contemplators, we really want to simply provide them some educational resources, and if they're willing and we have the time, some information regarding the dangers of tobacco use that they might want to consider, or if they have questions about how to quit, tools they can use, etc., we can provide those as well. So I will address the second half of Assess and all of Assist together. This is really our counseling component, and how much time you spend with a client will be determined by their need to some extent and your capacity to satisfy that level of need. Firstly, I want to say, if you're thinking of providing cessation services yourself, the Assess and Assist stages will satisfy the condition that most insurance payers, including Medicaid, have for a reimbursable tobacco cessation counseling session, if it is provided by a qualified provider. That is, don't confuse counseling in this context with therapy. To satisfy counseling, a qualified provider should discuss the harms of tobacco use in ways relevant to the consumer and the benefits they can expect from quitting. Counseling should also include an exploration of the consumer's triggers, their history with quitting, and identifying potential barriers. In addition to allowing us to check that counseling box, this information all allows us to create a quit plan tailored to their unique needs. Finally, some accrediting organizations want the advice or counseling piece to also include a pharmacotherapy recommendation. However, if you have opted to not provide any services yourself at all, and instead plan to refer your clients elsewhere for direct interventions, you may still consider assessing stage of change and dependency, as these will help significantly in making sure you're recommending the right intervention at the right intensity. And I won't go into too much detail on the topic of assessing dependency, but I strongly recommend adopting a single validated instrument organization-wide, and if possible, adding it to your EHR. The United States Preventative Services Task Force recommends the ASSIST tool. I normally recommend either the Fagerstrom test for nicotine dependence or the heaviness of smoking index. If there are questions about this, I'd be happy to answer them in the Q&A section. So, just to recap how performing ask, advise, stages of change assessment, and dependency might impact your workflow. I used here the results of the survey shared earlier in the presentation, the one using results from residential substance abuse facilities in Florida. And here we see that we are asking everyone who comes in if they are a tobacco user. Approximately 69% say yes, and they are then advised to quit, and also asked how ready and willing they are to quit. About 44% say they want to quit in the immediate future. And actually, this is actually a slight exaggeration. Normally, we would divide readiness to quit between those who plan to quit in the next 6 months and consider them contemplators. Within the next 3 months, we consider those as planners. And those who want to quit within the next 30 days, we consider them in the action stage. So they're the ones we're going to spend the most time with. So while I'm graduating 44% down to a dependency level assessment, it actually may only be those who are ready to quit in the next 30 days. The dependency assessment will tier the respondents into high, medium, and low. And then each of those then would require a different level of intensity of effort going forward. We don't have these figures for our survey respondents, but a breakdown like what you see here is pretty common in community behavioral health and substance abuse, where most users are going to be high or middle. And so finally, I want to talk about referrals. Consumers prefer as many services and products as possible to be available in the same transaction space. This is why department stores like Walmart and Target have added groceries. This is why Amazon is our most popular retailer. And it's one of reasons among many that integration is a driving force in our healthcare delivery sector. The more important reason is that there's no hard line between mental and physical health. Some mental health issues can cause physical health problems and vice versa. Some co-occur because they share a similar cause. So making sure that mental and medical care is provided at the same time by a team of individuals in continuous communications is essential in the treatment of a dependence as strong as nicotine causes. Which is to say that all things being equal, the more the services described above you can provide yourself, the better off the consumer is. Failing that, you want to find a resource for each service you don't provide. And ideally, you want to have a systemic link between you and those who refer to you and those that you refer to. If, for example, you routinely send patients to a nearby university setting for tobacco cessation group psychoed, you'd want to formalize a means of getting information about the patient's progress in that group back to their provider or the care team at your site. Similarly, if you regularly get referrals from a nearby jail or halfway house or something similar, formalizing the transfer of paperwork could mean that if they are screening for tobacco use or assessing willingness to quit, you could remove those tasks from your intake assessment staff, thereby reducing your workload on site. So 2 critical things about referrals. They have to be relevant and useful to the client. The client who has informed you that they are not available on Wednesdays should not be referred to a group that only meets on Wednesdays. This does not get a check in the provider referral box. Similarly, a referral to the quit line does not constitute a relevant referral if the client has insisted they don't want to use the quit line. Referrals should be made enthusiastically. We know as well as we know anything that seeking help for tobacco cessation can at least double the chances of success for any given attempt. So at minimum, the quit line, the group, a counseling session, a round of NRT, all of these things are better than nothing at all. Sowing doubt undermines the success before it begins, and we're going to return to this point. The final 3 bullets on this slide all go toward developing a robust partnership with your referral sources and those that refer to you. The more knowledgeable you are about the location, times, personnel, and unique characteristics of your referrals, the more comfortable your consumer base is with the referral sources that you send them to, the more appropriate you can be assured they are, the more enthusiastic your recommendations can be, and the better you can be about setting the proper expectations. So I do want to go back and talk about that enthusiasm point, and I want to illustrate it with just a few examples. A few years ago, BHWP partnered with National Jewish Health, who has several state contracts around quit lines. Callers to the quit lines were divided into 2 buckets: those who reported no mental health issues and those who did. Those who reported mental health issues were further divided into 2 buckets: those who thought their conditions would affect their outcomes negatively and those who did not. Now, In aggregate, those in the mental health bucket had lower abstinence rates at 6 months compared to those in the no mental health bucket. However, once we look at those who thought their condition would hurt their chances and those who did not think that, something really interesting pops up. Basically, those who thought their mental health condition would not impact their chances had the same abstinence rates as the no mental health group, while those who did believe that their condition would hurt them did so poorly it dragged the average down for the entire group. So we also see this show up in other areas as well. Every placebo pharmacotherapy, patch, gum, lozenge, nasal spray, inhaler, bupropion, and varenicline, performs worse than the real drug, but significantly better than if nothing had been provided at all. And back in the 80s, psychoanalysis was a really common modality for those seeking cessation. However, it became really evident that the psychoanalysts exercised too much power of suggestion over their clients. So if the psychoanalyst believed that the client, due to life stress, for example, wouldn't be able to quit, then that client performed worse than those clients the psychoanalyst believed would be able to quit. That is, the psychoanalyst's beliefs about the cessation success determined the cessation success. Just on this slide, there are some abbreviations. MT is Montana and ID is Idaho. This is part of a 6-state study, so those were the top and bottom range. Thank you, Larry, for asking that question. Essentially, in this world, it's worth keeping in mind that nicotine is an extremely addictive drug. It is legal, it is normalized, if not, maybe it could even be a moral activity in many of our consumer social circles, and it is still fully ingrained in our culture with movie characters smoking, billboards, magazine ads. So lapse and relapse are common. Your referral sources, no matter how good they are, will most likely have more failures than successes on their scorecards. But in nearly every case, some intervention and support is better than nothing at all. So make that referral enthusiastically because optimism is empowering. And so finally, we need to talk about a range. A range is simply making sure we follow up with our consumers at regular intervals going forward. We want to make sure we're checking in on them about questions and concerns they may have. We want to confirm they are taking any pharmacotherapies in the way that will control their cravings the best, etc. So we could spend another hour together simply looking at how to set benchmarks and how to engage in unintrusive formative evaluations and how to move data into meaningful action. Unfortunately, we don't have another hour together, but I do want to offer tips in that direction. Like planning, evaluation does not directly lead to financial return on investment. However, by improving process scores and potentially outcome measures, it helps to simultaneously enforce the organizational commitment to these services and adds to an organizational culture that values wellness, learning, and improvement. So where do you get those original benchmarks from? This can seem fairly daunting. If you have access to making your own EHR queries, you can start there. The best source for areas of improvement is what you've been able to accomplish in the past. This list assumes that that's not the case. Instead, refer to national, state, and county level data. National surveillance instruments like the Behavioral Risk Factor Surveillance System, BRFIS, can tell you what your state and sometimes county level prevalence rates are. You can then estimate or run a report to figure out if your particular catchment area is exhibiting a greater need for services. You may also be able to figure out your state quit rates and the success rates for various interventions. For example, if you know that statewide the Oregon Tobacco Quit Line has a success rate of X%, are those that you refer putting at higher or lower rates than that? Are there changes that can be made to your referral process that can improve those figures? Set both short and long-term goals. For example, if you know that you are currently advising 75% of the consumers that you screen, you may be able to make small changes early to move that figure to 85 in the first year, and then 90% by the end of year 2. That's a short and then a long-term goal. A long-term goal and a reach goal are different. A reach goal is something you want to achieve in the short term, but it's more like we will work very hard to get 90% of our staff trained in how to run groups, even though it's more likely that we'll get about 80%. A reach goal should still be conceivable, achievable, and realistic, but they're used for inspiration at the beginning, rather than for critical review at the end. And finally, be honest with your benchmarks and why you did or didn't hit them. As long as you moved in the right direction, or if you're confident you know why you didn't, it's a success. So when I was a social worker, each year the staff would gather to hear a bunch of organization-wide statistics. Some of these, when relevant, will be broken down into clinics and teams, and the staff in charge would say things like, this year, 60% of new intakes were diagnosed with a depressive disorder, primary or secondary. This would go on for hours, and the whole time I would just be getting angrier and angrier. What does that mean? Is that more or less than the year before? Is it higher at my clinic or at the other ones? Should we change what we're doing because of this? Do we need more training in depression, or are we over capacity? The point of collecting data is not just so that we have it. Just as I headlined the last slide as compared to what as the fundamental notion of where our first benchmark should come from, we want to pull our statistics into some context. Compare them across clinics, across providers, between cities. And here again, not just for fun, but in order to decipher meaning from the data and to determine actions from the meaning that we find. We're likely to get that wrong a lot, but that's okay. As long as our process is thorough and honest, we'll be likely to continue making progress over time, even if we miss the mark every now and then about when we're trying to pinpoint causality. So some important questions to consider in this exercise is this number higher or lower than previous years? Is the improvement or decline attributable to our own choices or to shifts outside the organization? Are these successes replicable? That is, can we take what we've done here and get the same successes in a different clinic or another office or on another team? And when numbers are low or if trends are going the wrong way, is that a fixable issue? Can it be solved through systemic fixes like additional training? Or is it a personnel problem? As you're thinking of new processes, there are two tendencies that should be avoided in this data collection realm. One is to collect no data at all, to just simply assume that since the intent of the change is well-meaning, that the end result will be good enough, even if below expectations. The other is to collect a lot of data, simply because once you're in the process of collecting some new things, you may as well collect everything. If you combine this slide and the last one, it implies an important piece of advice. Determine in advance how you will know if your program has been successful. Then collect whatever data you can that will quantify that success. Ask yourself, if on this date a year from now, if this number is X, what will that tell me? What directions will that give me? If you don't know the answer to that question, you might reconsider collecting it at all. So I'm going to pause on this slide for just a little bit. This is our final to-do list. These are the things that we discussed today that are concrete actions that we can embed in our current workflows or institutions that we can create to supplement that activity to help our clients maximize their cortex. So clearly I'm not going to go through each one of these headlines again, because to do so would take me approximately 44 minutes. But I can definitely provide this list to anyone that's interested. So now I'm going to very, very briefly talk about some resources, and then we're going to open it up for questions. Eagle-eyed observers, or those with clinical quality improvement experience, or those who simply enjoy diving into clinical improvement literature may have noticed that the 4 section titles of this webinar were Planning, Planning, Doing, and Study and Act. This webinar was structured around the Deming cycle, also known as PDSA, Plan, Do, Study, Act, or sometimes PDCA, and C stands for check. This is a user-friendly program improvement process with a long history of success in the healthcare delivery field. You don't have to choose this one to govern your activities, but we like it. The best program improvement tool or process is the one you'll stick to. If you are interested in using a rapid improvement process like PDSA, pictured here to the right is a form that we developed called the Dimensions Action Plan, which you can download off our site. It will ask you to set 2 SMART goals, that's S-M-A-R-T, SMART goals, as a way of measuring the accomplishment. It'll ask you for 2 SMART goals, ways of measuring each of those goals, and for a list of potential barriers. One note, take a good look at the barrier that you list. Is it something that will require a plan of its own to overcome? And if so, then make sure that overcoming that barrier is its own goal. So for a brief summary of the evidence-based best practices for tobacco cessation, check out our Dimensions Tobacco-Free Toolkit for healthcare providers, as well as several supplements for priority populations, youth, young adult, low SES, criminal justice system involved, and others. Much of the information used for this presentation is either in one of 2 other guides you can get from our website, the Patient-Centered Tobacco Cessation Workflow for Healthcare Clinics, and our Dimensions Tobacco-Free Policy Toolkit. And be sure to check out the website for the National Behavioral Health Network for Tobacco and Cancer Control. NBHN hosts lots of webinars and produces resources throughout the year to help organizations deliver tobacco services to their clients. And finally, use us. Come back to us. We have 2 more presentations scheduled in the next 2 months. The next one is on maximizing FDA-approved pharmacotherapy on March 19th. And the one after that is going to be on electronic nicotine delivery systems like e-cigarettes and Juul, and how to approach their use in the clinical setting. And that's on April 23rd. So that is all for me. So at this point, you can chat in some questions. You can use the Q&A function, and I'll receive those in a separate format. Or if you raise your hand, I can unmute your microphone and you can ask your question directly. And we do have one question already from Larry. It says, wellness committees are geared toward employees, are they not? They wouldn't make any policy towards clinical intervention. Not in our opinion, Larry. We do encourage what we call a parallel process, so that as you're looking at adding any sort of wellness programming, whether that's tobacco cessation, or you're changing the snack machines in the building, you're changing your lunch menu or whatever, we encourage you to look for ways of addressing the wellness or tobacco-related needs of both clients, clientele, consumers, visitors, and staff all at the same time, and writing them and presenting them as one large, robust strategy. It helps encourage those you're communicating to not consider these to be siloed activities. And so the way that we recommend to use a wellness committee is that when it meets, it's asking those questions for basically every audience that the organization comes into contact with. Thank you for that question, Larry. If you have others, by all means, send them in. I know that was a lot of material. We will be sending out the slide deck after this, but by all means, that email address that's there, bh.wellness@ucdenver.edu, that comes from, the email sent to there will go to a sort of a clearinghouse here at BHWP. A lot of us will see that and answer accordingly. We can provide not just resources that we have freely downloadable from our website, but also others if you're interested in something like that. But whatever that may be. Well, just to quickly clarify on Larry's last question, whether or not the Wellness Committee is empowered to actually make policy is a sort of an individual question that's left up to the organization. We encourage the Wellness Committee to be empowered to the extent of the highest authority on that committee. So we recommend that the Wellness Committee is staffed by people from all over, and including the highest up individual that's willing to sit on that committee, right? So we would like to see the dietitian on that committee. We want to see HR and or legal on that committee. We want to see clinical directors and supervisors on that committee. It's not uncommon to have peer or consumer representation on that committee, because when you start saying, like, we're going to do this, we'd like to do that, you want to be able to hear from everybody. And one of the, especially in this sort of, we're going to do new tobacco related stuff world, one of the good voices to include on your wellness committee are people who might be opposed to those changes. That is, if you have staff who smoke themselves or who for some reason consider smoking, say, with their client to be a therapeutic activity, rapport building or whatnot, it's good to hear those opinions. And it's good to present an identity that you're considering these other voices. I mean, obviously, I don't want it to be just rhetorical or just for show. It's not tokenism. I do want you to consider those voices for real, but you want to be able to, but there is that rhetorical component that you do want to convey that this is a committee that is listening to the potential complaints and responding, trying as much as possible to tailor the policies and new services or whatever that work best for everybody. You're going to get the most buy-in from. Sometimes that's not possible, right? I mean, there are some best practices here, and you don't really want to avoid those, but you do want to be able to respond to those voices. You want to be able to say, we're hearing you, we know, but here's why we're opting to do something else. So this idea that the Wellness Committee might or may not be empowered to make policy is, to me, slightly separate. If your executive director is sitting on the committee, then they are, or they can be. right? But in most situations, what the wellness committee is doing is drafting out ideas, maybe presenting plans. This is plan A, this is plan B, this is plan C. Plan A is our best option, plan C is third best, etc., and then proposing those to the policymakers for consideration and passage. Okay, not seeing any other questions, but I do want to make sure that everybody does get an opportunity. All right. Well then, everyone, I'll give you back 8 minutes of your afternoon than what you anticipated you would have. Thank you all very much for joining us. You will be receiving a follow-up email, and as part of that follow-up email, we will ask you to respond to a very short survey. I promise it's super, super short, but I'm open to all criticism and recommendations. As I said, there are 2 more coming up in 2 months. We have a third one coming up the month after that. We're working on the title and content for that one as we speak. But as you're thinking about your experience today, I definitely want to hear from you. We do use we do use that feedback to modify what we do. So thank you very much again. And with that, I will end the meeting and send you all on your way.